Dr. Gary Connett. Professor Gary James Connett is affiliated to the University of Hospital Southampton NHS Trust. He has got a special interest in the treatment of cystic fibrosis and is the director of Southwest Pediatric CF Service. And Professor N. Somo oration was delivered by Gary Connett in the year 2017 during our Respicon. Sir has got more than 100 publications and all were PubMed indexed. Now we have a talk on how do I prescribe antibiotic in CF. Over to you, sir, please.
Thank you very much. I'd like to start just by echoing Julian's comments and say a really big thank you to the Respicon team for inviting me here to speak today. It's been a really fantastic conference for me. It's been great networking with people, and we also had some very entertaining cultural experiences last night. The only slightly worrying thing for me is that my colleagues and some of my trainees now have videos of what my daughter would call me doing dad dancing. So I'm not quite sure where that's going to go when I get home, but nevertheless, I still enjoyed myself last night. It was great. Julian's already told you a little bit about where we come from. I thought in preparing for this lecture, I'd look up Southampton, and a little bit worried to see that when I Googled it, it came up as being one of the 50 worst places to live in England in 2023. I don't think that's true, and if any of you are ever to come to the UK and visit me, I'll do my best to prove that that's not the case, and actually it's not a bad place to be at all. Some of you will testify to that who have already been to see me. So my brief today is to talk about antibiotics, antibiotic therapy for cystic fibrosis patients. And I think it's worth thinking about this by breaking it down into three areas. The concept of prevention treatment, the idea of eradication, particularly in relation to the number one bacteria we deal with, Pseudomonas aeruginosa, and then the issue of trying to control disease when we have chronic infection with that and other bacteria. So we'll take those three things bit by bit, and I'll give you some information about about all of those. So we'll start with prevention. And my starting point with this is going back to our Hippocratic Oath. And one of the things that we as doctors have an obligation is to do no harm to our patients. Primum non nocere. First, do no harm. And this is quite relevant to the concept of giving a treatment as a preventive strategy in an otherwise well patient, trying to do something before bad things happen. And we have to be very beware of unintended consequences when we do this. So what does that mean when it comes to prevention treatment in cystic fibrosis with the use of antibiotics? Well, one of the big advances we've had in microbiology in the last 10, 20 years is the idea of the concept of the microbiome, the presence of many bacterial species which coexist with us. We are as many bacterial cells as we are human cells, and we've now got these culture-independent techniques of being able to understand that in far more detail than in the past. And what we learn from this is that the lungs, the airways in particular, are not sterile. There are many interacting species, like on the side of this stream here showing flowers, which are living in harmony with us. And what we've learnt about infection in this context is that what happens is we get a loss of diversity. One particular bacteria takes control and increases in its numbers to an extraordinary extent, which then leads to inflammatory responses from both the host and the bacteria, which leads to a battlefield of lung damage that we see within the airways. But similarly, antibiotics can also have an effect on that normal flora, and although the population may be at a lower level, you do get loss of diversity. So is that relevant to cystic fibrosis? I think it is, and we have to have this concept, I think, of antibiotic stewardship. And the idea here is that we have to use our antibiotics judiciously and be aware of the risks of emerging pathogens as a result of what we do. And this is one of the most important papers for me in the CF literature. It's an American study It's 7-year data on infants who were randomized to either have cefalexin, an oral cephalosporin antibiotic, or placebo. And they watched these patients for 7 years. And what they showed was that while Staphylococcus aureus, an early bacterial infection that we see in cystic fibrosis, the numbers went down from 30 to 6%, Pseudomonas increased. And the frequency with which that was seen doubled from 13 to 25%. And Pseudomonas has a far more important long-term consequence for our patients than Staphylococcus aureus. Haemophilus is also an important pathogen, and that wasn't actually affected by this treatment. Now, in the UK, we use a drug called flucloxacillin. It's a relatively narrow-spectrum antibiotic, and it's used to try to prevent staphylococcal infection early on. But here you can see, this is the meta-analysis from the Cochrane database. And over time, what you see is those charts going towards the right is an increasing occurrence of Pseudomonas, even after just using flucloxacillin. Not quite reaching significance there, but a worrying trend. And we're currently in the UK doing a study called CFTR. It's a Cystic Fibrosis Trust database study where we're randomizing patients to either have flucloxacillin or not to try to answer this important question. If I was a betting man, I'd be betting that we'll be stopping flucloxacillin in the near future in our country, which is no bad thing. So what about eradication? So if we first find Pseudomonas in the airways, an important concept is try to hit it hard when we first see it. Try to prevent it from adapting within the airway, expressing its biofilm mode of growth, and becoming a permanent residence within the lungs. A few things about Pseudomonas. It's a fascinating organism. It's a gram-negative rod, and allegedly it's the most abundant organism on the earth. It's everywhere. It's in our sinks, it's in the mud outside. It's a very prevalent organism. And it's one of the few organisms that can infect both animals and plants. We have colleagues who have been investigating that within the plant kingdom as well as in humans. It can respire both aerobically and anaerobically, and you'll know that the airway is a micro-anaerobic environment which Pseudomonas is particularly successful at growing in. And it does all this because it has this very large genome. It's quite a complex bacteria, and it's got many different regulatory genes. And what it does is it expresses those differentially within the airways wherever it happens to be. You tend to get just one clone of the bacteria, which massively expands, but behaves very differently in different parts of the airways. And one of the most important things it does is express this biofilm. And that biofilm helps to ensure its survival within the lungs, because antibiotics find it very difficult to penetrate and to address their bactericidal effects when that biofilm is present. Here's some interesting Cystic Fibrosis Foundation data, and it's looking at modeling of lung function in pediatric patients, and you can see there that the lung function is lower in patients with chronic Pseudomonas versus those who occasionally have that bacteria versus those who don't grow the bacteria. So it's clearly one of the most important things after, I would say, nutrition, that is relevant in determining the outcome for patients. So the idea of eradication therapy, I think, is really important. How do you do it? Well, if the patient is sick and growing Pseudomonas, they should have intravenous antibiotics. And we tend to use 2 antibiotics. We believe that attacking the bacteria at different angles with different modes of action of antibiotics is the right way. And we tend to use ceftazidime as our cephalosporin and tobramycin as our aminoglycoside as our first choice agents to address this bacteria when we first see it, if the patient is unwell. If the patient is not unwell and it's a pickup in a patient at a routine clinic visit, then we've done research in the UK which showed that the outcomes are similar with an oral and nebulized antibiotic approach compared to giving intravenous antibiotics. So we tend not to admit and give IVs if we see a well patient with this bug for the first time. But we attempt to eradicate with, in our case, nebulized tobramycin, and we also tend to give the oral cephalosporin ciprofloxacin for at least a month to try to clear that organism when we see it. So eradication, a really important concept to try to prevent the onset of chronic infection and that biofilm mode of growth and the permanence of the bacteria in the airways. So what about control of infection? Well, I think one of the best studies that was done to show the benefits of trying to suppress Pseudomonas, decrease the bacterial load within the airways, has been the use of long-term nebulized tobramycin. And this is a study that was done in the States. Again, it's 24-week data, and it's looking at the benefits of month-on and month-off nebulized tobramycin. And you can see a bit of noise there between the month-on, month-off cycles. The concept behind why that is being done is a little confusing, but it may be due to trying to prevent the emergence of large numbers of more resistant expression of genes against aminoglycoside treatment. But certainly there appears to be long-term benefit with that approach. And what we're essentially doing is just not getting rid of the bacteria, but trying to minimize the extent to which it's there, and therefore causing an inflammatory immune response and lung damage over time. You can't talk about CF without mentioning azithromycin. This came up yesterday when we were talking about bronchiectasis, and this antibiotic, I sometimes wonder if it is an antibiotic. Interestingly, if you look at cystic fibrosis and the culture-independent look at the airway, it's not actually altered by the use of this drug. Azithromycin is not bactericidal against Pseudomonas, but its use, particularly in patients who are chronically infected with that bacteria, does result in improved outcomes, improved lung function over time, and a decreased rate of exacerbations. So if you're unfortunate enough to be chronically infected with Pseudomonas, in my country, you get long-term azithromycin treatment, and that does have some benefit against the patients. It's probably working as an anti-inflammatory agent. It may be modifying the host immune response, and it may be in some way affecting the biofilm behavior of the bacteria in a way that's also beneficial. But it's not bactericidal against Pseudomonas in the conventional way that we think about antibiotic use. Other bacterial pathogens to mention, we're very fortunate not to have a lot of MRSA in our country, but I think the message there is that, like Staph aureus, it behaves as a CF pathogen. So if you see it, you treat it in the same way as you would do Staphylococcus aureus, but of course being aware of the different sensitivities to antibiotics. Sensitivity testing does matter for your choice of antibiotic for MRSA. Burkholderia cepacia, again, very fortunately, we very rarely see that bacteria, but if you do see it, it's a worry. It's no doubt associated with even worse disease progression than chronic infection with Pseudomonas, so we treat that bacteria very aggressively and try to eradicate it if we see it. Those patients go into not quite solitary confinement, but we're very much aware of the potential for cross-infection with these kind of bacteria, and we will see that patient quite separately from the rest of our patients, and we will be paranoid about glove wearing and hygiene practice to minimize the risk of that bacteria getting anywhere else into our patients in our clinic. If you see it, be scared, I think, is the message. Non-tuberculous mycobacteria, these are emerging pathogens that we see. Their treatment, I think, is quite complicated. Again, sensitivity testing is beneficial, and the treatment recommendations that we're following are quite prolonged, sometimes up to a year, because these bacteria can quite indolently cause quite significant disease progression. Again, fortunately, we rarely see these now. And there's a whole bunch of other gram-negative bacilli, which we also should pay attention to. We get a lot of these kind of reports for these Pseudomonas. We have a technique called modulator, which has a means of identifying quite a large range of gram-negative bacteria in our service. And I think that on the whole, these are mostly harmless. They don't cause chronic infection in the way that we see with aeruginosa, Pseudomonas, and we rarely treat them unless the patient is obviously unwell. So a slightly different approach to these other types of Pseudomonas, which I think are not quite as clever and is evolved with the same genome as Pseudomonas aeruginosa has. But these bugs we should take notice of. We've had patients with extraordinarily severe disease with Stenotrophomonas. That bacteria often responds to oral septrin, cotrimoxazole, and these other bugs, Achromobacter, Alkalagenes, Ralstonia, and Pandaria, all quite rare in our practice, but still significant bacterial pathogens when seen. So other considerations, don't use antibiotics indiscriminately. I've already said that. Do make your treatment decisions based on microbiological results whenever possible. Curiously, when we come to using intravenous antibiotics against Pseudomonas, sensitivity testing doesn't actually matter. Many studies have shown that what you show in the lab in terms of what the bug responds to does not dictate which benefits you get from whatever antibiotics you use. Quite complex reasons for that, all to do with the differential expression of those complex genes throughout the lungs. But an important point, use what works, what's worked before, and don't worry too much about what your lab says about the bacteria being sensitive or not. That's what we certainly find, and that's much research to support that. Quickly mentioning this condition, this is a child that's got wheeze, with cystic fibrosis and breathlessness, and they've got some central lobar shadowing on their chest x-ray, so that patient has got allergic bronchopromyaspergillosis. It's worth noting that there are risk factors for that in relation to antibiotic exposure in cystic fibrosis, so you're sometimes walking a tightrope there about treating bacteria aggressively and the risks of seeing ABPA as a problem. And you've got your own guideline I learned yesterday from the presentations from Dr. Matthew, George Matthew, yeah. So that was very useful to see that you've got your own guideline, which I think is very good. I agree with everything that he had to say about that. Julian's mentioned this drug, quite transformative for our patients. He's told you that the bugs are going away and a 90% reduction in our IV antibiotic use. Seen nothing like that in my career. It's been so great to be doing what I do at this stage of my career and seeing those benefits to my patients. And I do hope that you get these drugs for your patients as well. We need to be shouting at the doors of government and advocating for them as much as we can do. I think what they're doing is reducing the antibiotic load. They're just taking the number of bacteria down. The bugs are still there, do be aware. We still occasionally see them when we get good sampling, but the numbers have gone down hugely. Just to finish off with very briefly, I looked at the Cystic Fibrosis Foundation pipeline for anti-infective agents, and there's a few things on the horizon to be aware of. One of them is gallium. Gallium is what's called a Trojan horse element. It looks like iron to the bacterial cells, so it gets inside those cells and it then disrupts iron-dependent electron exchange. It messes up metabolic pathways, and the bits of iron left outside then cause cell destruction to the cell membrane. So, and quite a nice, potentially useful drug, not just for anti-infective agents, but maybe also for cancers as well. Our Eastern European friends, the Russians, have been using phage therapy for a very long time. And this is something that's creating a lot of interest now in cystic fibrosis. The concept of having viruses that don't infect human cells, but infect bacterial cells, and might well be a benefit. Another gallium drug on the horizon there by inhaled formulation. And This is a young character from The Incredibles who's a little bit like Pseudomonas aeruginosa. She's got a force field around her to protect her from being attacked. And Pseudomonas, as you've already heard, has a similar thing, a biofilm around it to protect it from being attacked. And one way of disrupting that biofilm is to give nitric oxide. And we've done some work on that in Southampton, using it as an adjunct to IV antibiotics. We showed some evidence of benefit, but the logistics of giving it was quite complicated. And I'm not sure how practical it is as a treatment, but there's some evidence of benefit for this approach. There's a new inhaled azole for Aspergillus infection, which is quite exciting. The oral azoles do have side effects, but an inhaled drug might well have some really important benefits. And then finally, there's a drug which might help mitigate against the risk of deafness from aminoglycosides, a problem we see with repeated exposure over time, which might also be a benefit. So I hope I've given you a little bit of interest there about antibiotic usage and some ideas about what's there in the future. So thank you once again for inviting me to be here, and I'll take any questions.
Now house is open for any questions.
Thank you very much, Gary, for an excellent presentation. My question is, do you have any experience of using IV antibiotic as well as inhaled antibiotic during pulmonary exacerbation?
Do I have an experience of IV as well as inhaled antibiotics?
During pulmonary exacerbation.
Yeah, I mean, when you're in a dark place with a very sick patient, what are you going to do? You're going to throw everything at them that you can do. And we've all been there, I think, where we are not getting the effects we would hope for. We sometimes would review our antibiotic choices intravenously. If a week down the road we're not seeing any obvious benefit, well, then we'll try something else. And it really is a finger in the air as to which IV you might choose, but maybe a different class antibiotic if you have one that you can throw at that patient. And yes, I think drug delivery by the nebulized route can actually increase what you're throwing at Pseudomonas, and it's worth an attempt, certainly. The other thing that we occasionally do, and again, there's not good evidence for it, is the intermittent use of oral steroids. And we might throw some prednisolone because we have to be aware that the lung damage is a lot to do with what the host is doing, as well as what the bacteria are doing in the release of elastases and other kind of proteolytic enzymes. So that's my other little thing, is back to the wall. If in doubt, use steroids if you've already given good antibiotic cover.
And next question, last question probably. So there are systematic review and meta-analysis, good Cochrane data, which showed that even if we are giving prophylactic antibiotics, so there is no improvement in lung functions, particularly FEV1. So how will you take this? If we are giving inhaled antibiotic prophylactically, then there is no improvement in lung functions in CF patients. So we are having good Cochrane data. So what is your take on this?
I guess it's what's the outcome that you're looking for in that scenario. And I think you don't always get what you hope for in terms of an improvement, but then I guess the question is, are you preventing disease progression, and are you achieving stability? And I think that's a lot of what we're trying to do in the outpatient clinic with these patients. We're not necessarily doing anything that's going to make the patient dramatically better, because CF is a progressive disease, but what we aim for is a prevention of exacerbations which are associated with marked deterioration by a package of care that keeps bad things from happening. I think, and so maybe I would keep the faith and hope that we are preventing deterioration rather than looking for a big improvement in lung function.
Thank you, Gary, for that wonderful lecture. When we are dealing with patients with CF, sometimes we get a lot of MRSA, which is almost difficult to eradicate. And I've seen this in older children Pseudomonas is not there, but MRSA is equally difficult to eradicate.
Yeah.
A word on that. And my second question is, we land up giving nebulized aminoglycosides in people who are colonized with Pseudomonas almost continuously, not intermittently as you suggested. And I've read some papers that continuous nebulization. A comment on that.
Okay, so I don't see much MRSA, so I'm not an expert to comment on that, but it certainly is a CF pathogen. There's some very curious adult data that looks at chronic infection in cystic fibrosis, and there's no doubt, I think, from looking at that on the whole, Staph aureus is less serious in terms of the long-term consequences. Chronic staph infection is with improved survival than chronic Pseudomonas infection. So I'm sometimes left thinking, well, better the devil it could be, and we'll live with the Staph aureus, the MRSA, and do what we can to suppress it when there's a change in status, if there's an exacerbation. So that's one way of perhaps thinking about it. So there may be a silver lining to your chronic staph because it's not Pseudomonas, and maybe it's displacing that bacteria from being the main culprit, which is associated with more severe disease. So that could be what's going on. And then you asked about
regular use of nebulized.
So
aminoglycosides.
it's certainly an advocate for that. Using it before we see Pseudomonas, I'm not sure is the honest answer, and I worry about what bugs you might be encouraging to emerge because you're not treating the one that you're worried about. So I don't know. I'd be cautious. But I mean, I guess you want to do microbiology and see what you're getting as a result of that approach.
Thank you.
Thank you for that excellent lecture, sir. I have just one question. You mentioned that there was a change in the microbiome structure in the airway. Is there any possibility for reconstituting that through an inhaled microbiome?
Yeah, it's a great idea, isn't it? I mean, it's been done for the gut, as I'm sure you're aware, and that's been quite a tantalizing thing. I have colleagues with whom we have these conversations, and it's quite tantalizing, isn't it? You know, if you had a pseudomonad that was mostly harmless and didn't cause a great immune response, why not inhale that into your airways and have it take over the lungs and displace Pseudomonas aeruginosa? It's a great idea, and I think it's one that is certainly worth thinking about.
Yeah, we'll have a last two questions because time is short. Over to Dr. Kishan.
In case of a child who is fast deteriorating and suspecting Burkholderia cepacia as offending organism which is known to cause fast deterioration, it is a dangerous organism. So which antibiotic will be most appropriate empirically on clinical suspicion only?
Empirical treatment for Burkholderia cepacia. B. cepacia, treatment for B. cepacia.
Yeah. I mean, B. cepacia is a terrifying bacteria. I'm not sure you can do anything prophylactically about it. I think all you can do is have surveillance, early identification, and aggressive treatment, very aggressive treatment. There's something called cepacia syndrome, which can be quite severe with a huge systemic illness that is well described with that bacteria. So if you ever see it, don't ignore it. Yeah, 100%.
Thank you, sir.
Okay. Those patients of CF who are reasonably stable, or those who are not doing too well but are at home, and the third category who need hospitalization, when would we ask for a sputum culture in these three different categories of patients?
Yeah, I mean, I haven't talked about the microbiology and the sample collection. I guess the important times, we do two things. I mean, we see patients routinely in the clinic and we take some specimens for culture to see what's going on. But I think it's particularly important at time of deterioration to try to understand the reasons why, and that's probably the most important time to try and get some good microbiology. We would empirically start antibiotics if the patient is sick, but then that microbiology would then help us reassure that we're doing the right things or if we need to change practice.
When they are bringing out sputum, is it a good idea to discard the first part and take it a little later part that they bring out from deeper in?
I don't know. It's a big subject, so we can talk about sputum for a very long time. Maybe we can talk afterwards.
Thank you.
Thank you very much for that wonderful deliberations and answering all the questions.